working in our OPD. So over to you, sir.
Thank you, Manisha. Just let me know if you can see my slides and can you hear me?
Yep. Yes, sir, we
Yes,
can
sir.
see
We
you.
can.
Go ahead.
Good evening, everyone. Thank the VRSI, particularly Dr. Manisha and Dr. Anand, for this opportunity to meet you all virtually this evening. So let's look at how the workflow in the retina OPD changes in this COVID era. So many of these things are common to the anti-segment surgeons as well as post-segment surgeons. So many of these I have picked up from the IGO as well. So what are we doing at our hospital now? At entry, there is somebody who checks the temperature of the patient, gives sanitizer to the patient as well as the attendant, and ensures that both of them are wearing a mask. So if they're not wearing a proper mask, we give them a mask as well. And then we ask for the history. This is a column which I picked up from the IGO. We ask for history of symptoms and history of exposure, and towards this the patient has to give a declaration absolving the hospital of any responsibility subsequently, but then I know how good it will stand in the court of law. But they are expected to give a declaration about this signed by the attendant as well as the patient. This column and this declaration you can find in the IGO, the recent IGO article. So let's look at a symptomatic patient. If there is a history of fever, shortness of breath, cough, and recently in one of the international webinars they mentioned diarrhea as well, or if there is history of direct uh, exposure to contacts or high-risk contacts, the definition of these, once again, you can find in the IGO article. And if the patient does not have any after emergency, then we would defer an eye examination and refer to the COVID center. All this happens at the gate of the hospital itself. If the patient has these symptoms or exposure, and if there is an ocular emergency, then the patient is taken to a designated isolated area, which is away from the main hospital complex. And there is a team which is equipped with full PPE, and they do a quick examination, may not be a detailed examination, quick examination, and give them the treatment and then refer to a COVID center. And all the patients, the healthcare workers, the attendants, and any person who comes to the hospital is expected to fill in their information. So the hospital has their information along with a verified mobile number as well as the ID proof. All this is easily possible with the RIQ Setu app. This Setu app also tells us if the patient is potentially a COVID positive patient when you are approaching them. So I would suggest, and some of the hospitals actually insist that the patient has this downloaded and they check if the patient is listed in the app or not. And so this is a good app to have, and all the hospitals should probably use it to screen their patients at the entry. And to track these patients is particularly useful. Now, once the patient is not symptomatic, or rather the asymptomatic patient enters the hospital, we follow this distancing everywhere. So this is the picture of the reception. The plus marks are where the patient stands from another person. And you can see there is desks here, which is separating the reception staff from the patient as well as the attendant. And this is the waiting area. You can see that in a three-seater, we expect only one patient to sit. If at all the patient's attendant can sit here. So we have numbered them so that the patient is expected to occupy this seat from the beginning of the examination to the end of the examination. And we limit the entry to the hospital to only one attendant. And we see limited patients in an hour, and it's preferably by appointments so that the overcrowding within the hospital complex is avoided. Next step, if it is a postoperative patient where the vision check is not required, we fast forward the whole thing, see the patient by the consultant and send the patient off if it's a postoperative consult. But if there is a need for a vision check, then this is an optometrist. These are the personal protective equipment, the optometrists, and pretty much all of them were in the hospital. There is a face shield, there is a mask, a three-play mask. And in our hospital, we have been offering gloves to almost all of them. And as you can see, the patient also wears a mask. Refraction only in select situations is done, and NCT is something which is to be avoided. Now moving on to retina specific, what do we do in the OPD? Dilatation, if it is possible, and if we know about the patient and the patient is unlikely to have a shallow anterior chamber, it's a follow-up patient, we can ask the patient to dilate themselves at home and come over. Otherwise, if you were to dilate in the hospital, as you can see, the sister is not touching the patient. The patient herself retracts the lower lid, allowing us to apply the drop. And in case of patient is unable to retract the lower lid, you use a cotton bud like this to retract the lower lid and put the eye drop. So this is the current PPE which we are using. I use a cap. a protective goggle or a shield, a 3-ply mask, and a scrub. So once we come into the hospital from home, we change into the scrub. And just before leaving the hospital, we change back to our street clothes and gloves as well. And pretty much the same thing the sisters also wear, except for the fact they wear a uniform rather than the scrub suit. So cleaning is something which has to be done through the day, through the hospital. And as soon as a single patient is examined, the slit lamp, where the chin rest, the forehead restraint, and as well as the chair is cleaned with alcohol. The floor, door handles, contact surfaces are cleaned by the house cleaning team every 2 hourly. And particularly, the restroom has to be cleaned, and this has to be looked into as well, because that's one of the potential areas for spread. So, opening the door is something which can be a tricky issue in many of our places. So, we have devised something like this. So, in particularly the restroom doors which are spring loaded, and when we have to pull, we have to touch the knob, which can be touched by many people. So, we have devised one strap in which you can put your foot in and remove it. And this is like a very simple solution is to have these pieces of newspaper cut and hung next to the door. You tear one newspaper, use it to hold the doorknob, open it, and then throw the newspaper inside. So this way, you cannot be having the solution, the alcohol solution within the toilet. Instead of that, you can use this to not to touch the knob. So this is a very simple solution which can be done. Coming on to examination room, we prefer not to use air conditioning. Of course, being in Bangalore helps. And we have open doors policy. The windows are also kept open. And coming on to examination techniques and the equipment which you use, all of us are familiar with this slit lamp shields and how to make them. So there's an acrylic shield which is cleaned at the beginning of the day as well as at the end of the day. You can wash them, take it off and wash them, or you can use alcohol swabs as well. And this is a much more elaborate slit lamp shield. Of course, on the other side, you do have a bed shield as well. So this is on the patient side, and some of us do have this elaborate shield in addition to this bed shield which you can see. Now moving on to how do we do 90-day examination, we have modified the lens like this. We have wrapped the lens with the cling wrap. So as you can see, despite the cling wrap, you can see it quite well. So prefer not to touch the patient. He is touching the slit lamp forehead thing. Yeah, this is without the cling wrap, and this is with the cling wrap. You see one extra reflex, but it's good enough to see. As soon as it is over, it's sprayed with the 99.9% isopropyl alcohol and left there. Of course, the other alternative is to wash the lens, but it's particularly difficult and likely to scratch the lens after each examination. So you can cling wrap the 70 diopter lens, which helps in examination as well as keeping it clean. And as you can see, when the sister is spraying, she is spraying on her gloved fingers as well, so that gets sterilized as well. Coming on to the indirect ophthalmoscopy and the laser indirect ophthalmoscope. So this is the shield which is we have loaded onto the indirect ophthalmoscope, and many videos and many images are available on the net as to how to make them. This is essentially the sheet with which we put the FFA photographs. So that is the sheet you can design them to make it as a face shield. There is a cutout here, so this is not obscuring your vision and doesn't get to fog. And through this cutout is where the indirect ophthalmoscope sits here. Coming on to how do we do the indirect ophthalmoscope in our place. So use alcohol scrubs. And here he is already wearing the face shield. This again is a modified lens. Either we wash the lens after each case, but here we have loaded onto a PVC pipe, and on the other side there is an acrylic sheet. The same sheet which comes in the face shield. We have made it like this. You can see it's a decent view. So though there is one additional reflex, but when we are doing this indirect ophthalmoscopy, as we can see, our fingers are touching the patient. So before we take off the indirect, we use alcohol so that we don't touch the indirect with contaminated hands, and also spray the alcohol on the lens as well as wherever we have touched. And we can actually spray it onto the lens very easily because the lens surface is covered by this plastic sheet, so the lens doesn't get affected, and it can be used through the day. So there's a modification we have made of the +20 diopter lens. How do we examine an ROP in this era of COVID? So the child is swaddled in a plastic sheet in addition to the regular cloth swaddling which we use. And us, we cannot put a mask on the patient. Us, until now, all the adult patients have been wearing a mask when we have examined, but a child, we cannot put a mask, and it keeps screaming and crying, so possibly liberating a lot of aerosol. So it's better that the examining team wears a preferably an N95 kind of a mask, not a simple three-ply mask. For other examination, we use a three-ply mask. IDO with shield is what is to be preferred. A disposable glove is again worn when we examine a child with ROP. And when the IGO, they have mentioned a sterile gown, that's something which is up to us. But all this is if there is no history of COVID. If the child is known to have COVID, or if the parents have been known to have COVID or exposed to contacts who have COVID, then that's better that this child is examined with full PPE in a COVID center. So now moving on to the investigations which we commonly perform in the clinic. So this is a patient sitting in the OCT with the mask in place. Most of the time, what happens, there is a gap here, and the patient sits in the front of the OCT and breathes. There's a possibility of the breath getting deposited onto the lens. That's the reason and the next patient comes very close to this particular deposit. That's the reason I was wondering whether we can cover it up. So we have done this. We wrapped the OCT with the cling wrap. It's very simple to do. So this once again is to prevent us from cleaning the OCT lens repeatedly. We can use this cling wrap, and the OCT procedure is pretty much done in the same way. Actually, we find that like even Opta can be done with this cling wrap in place. You can see the images are pretty good. Only downside is there will be this reflex. So the color photograph will not come properly, though the OCT images come beautifully. Now, how do we do an ultrasound? So we spray with alcohol, clean the probe, then put the gel and go ahead with the ultrasound. The only change is like the surgeon is wearing a glove. Otherwise, you better that like we put a cap on the patient, new cap on the patient, because sometimes you may have to hold the head of the patient to do the ultrasound. So better to put this cap on so that like the surgeon's hands are not contaminated. FFA and ICG, I would avoid in the present situation, and would suggest doing this only in absolutely unavoidable cases, because it's a long duration investigation, may take about 10 to 15 minutes in a closed room. There's a risk of blood spill, though Dr. Atul mentioned that it's unlikely to be hematogenously spread, but potential for aerosol is quite high because the patient can retch during an FFA and ICG. So how do we do a laser? And PRP, if we have a single spot laser machine, I would suggest we do it with the LIO. So this is how you clean the lens, only the surface which goes onto the cornea. And that is good enough. But if you want to clean you want to cover the laser as well, you can cover it with the cling wrap. As you can see, these are the burns without the cling wrap, and this is with the cling wrap. You can see the burns are a little bit smaller, but it is possible to get good burns despite the cling wrap being on in place. So if it is a multi-spot laser, then it's better to do PRP with a multi-spot laser. So you just clean the laser at the end of it like that. And if you have a single spot laser on a slit lamp, it's better to do an LIO when you don't want to do a PRP. So how have we deployed our manpower? We have divided the whole team into two teams, and one team works in the morning, one team works in the afternoon, and the team should not meet physically. For instance, if you come across one patient who has COVID, then the whole team is likely to be quarantined, and the hospital work should not it should not be interrupted. So we have divided ourselves into two teams, and we function in shifts. And people cohabiting, for instance, a husband and a wife belong to the same team, or people who are in the same apartment complex or from a individual house, they form in the same team. So to summarize, the whole aim of this presentation is to avoid getting infected or transmit the infection when delivering care. The bottom line is we have to protect our eye, nose, mouth from aerosol and fomite. I thank Dr. Debashish and Mr. Balu, our electrician, who were able to put every idea of mine into practice, and the biomedical team of Shankaraya Hospital.